Hello, dear colleagues. I try to explain acne and treatment. Epidemiology, acne is an almost universal disease. Acne's prevalence peaks between age 14 and the start of the third decade. In a survey of 48,616 employees in Germany, the overall prevalence of acne was 4.2%. In the sub-analysis, the prevalence on the age group 16 to 20 years was 24.8%. Up to 40% of women over 25 years of age still have acne. A prevalence of late-type acne, especially in patients with a genetic predisposition, to be as high as 50 to 53%. Etiology, hormonal function, especially DHEAC, increased sebum production, follicular hyperkeratinization, proliferation of Propionibacterium acnes, various cascades of inflammation. Severity. The severity of acne in adolescence is associated with a positive history of severe acne in first-degree relatives, especially the mother. Many inflammatory pathways and factors are involved in acne pathogenesis. However, the initial inciting stimulus has not been identified. Propionibacterium acnes, several inflammatory mediators, cytokines, defenses, peptidases, serum lipids, and neuropeptides. Yes, modern aspects of the pathogenesis of acne. Androgens, especially dihydroxyepandrosterone sulfate, play an important role in the early pathogenesis of acne, leading to larger sebaceous glands with increased sebum production. In addition, androgens stimulate the keratinocytes of the sebaceous duct and infundibulum. Excessive androgen production leads to increased sebum production and acne of varying severity. Skin not responsive to androgens produces no sebum and develops no acne. Lipid synthesis requires androgens and peroxisome promoter activated receptors. Yes. Neuropeptides can control the development of clinical inflammation in acne. Substance P can be identified in numerous immune-reactive nerve fibers of acne skin, and sebaceous glands respond to it with the synthesis of the inactivating neutral endopeptidase. Synthesis of chemokines and cytokines by keratinocytes can be stimulated by certain Propionibacterium acnes strains through the activation of Torac receptor 2. Yes, you see serum lipids induce Torac receptor 2, Propionibacterium acnes, protease activated receptor 2, and Torac receptor, PPAR, peroxisome promoter activated receptor, induces cytokines, defenses induces cytokines, and stress induces pro-inflammatory neuropeptides, and peptidases induce immunocompetent cells. Yes. Inflammatory events during acne lesion development increase the expression and bioactivity of pro-inflammatory mediators. Upregulation of inflammatory mediators in uninvolved skin and early lesions. E-selectin, vascular adhesion molecule 1, interleukin 1, integrin, interleukin 1 alpha bioactivity in open comedones, upregulation of defensin 2 immunoreactivity, elevation of CD3 plus and CD4 plus T cells and macrophages in uninvolved skin. Peptidases, extraction of pro-inflammatory peptidases on sebocytes and keratinocytes. Inhibition of peptidase activity leads to an anti-inflammatory profile. Neuropeptides, upregulation of neuropeptides in uninvolved skin via corticotropin-releasing hormone, melanocortin-1 receptor, substance P. Thorac receptors. Activation by Propionibacterium acnes triggers inflammatory cytokine responses. P. acnes is present in sebaceous follicles undergoing comedogenesis and may play a role in comedo formation. Activation by endogenous ligands. Changes in lipid biosynthesis. Confirmed association between sebaceous lipid synthesis and inflammation. Peroxidated lipids trigger inflammatory responses. Clinical criteria. The anti-inflammatory dapsone is effective in treatment of non-inflammatory lesions. Dapsone has multiple anti-inflammatory properties. Retinoids are effective in treating non-inflammatory lesions. Retinoids downregulate thorac receptor 2 and interleukin-10 expression. Chronic course. Acne is not a short-term illness, but instead shows a chronic course with persistence over years. Acne is chronic disease using the WHO criteria. Acne compared with another chronic disease, atopic dermatitis, major feature, duration, genetic background, age of onset, spontaneous remission, recurrences, follow-up, therapy, social counseling, physiological counseling, scarring. Exacerbating factors of acne: diet, menstruation, sweating, personal stress, ultraviolet radiation, application of pomades, and occupation. Hyperinsulinemia. The relationship between hyperinsulinemia and elevated IGF-1 and reduced IGF binding protein has been increasingly supported by controlled case studies. Smoking. The relationship between the number of cigarettes smoked daily and the severity of acne is controversial. Diet and acne. Relates to hormones. As milk is meant to increase the growth of cows, it naturally contains growth hormones and anabolic steroids. Relates to carbohydrate. Content of dairy products with related effects on serum insulin and insulin-like growth factor 1. The Western diet has also been researched as a potential cause of acne. Low glycemic load diet, improvement of acne, improvement in insulin sensitivity, a reduction in testosterone availability, and a decrease in adrenal androgens. Therapeutic agents of acne: inhibition of inflammatory cascades, reduction of follicular hyperkeratinization, suppression of the effects of androgens. Yes, you see choose of treatment according to lesion types, comedonal lesions, mixed comedonal lesions, and papulopustules, stick lesions. Comedonal lesions prescribe one of the following topical retinoid, benzoyl peroxide, salicylic acid, azelaic acid. If results are unsatisfactory, increase strength or change medication. Mixed comedonal lesions and papulopustules, retinoid plus topical antibiotic, or retinoid plus benzoyl peroxide, or retinoid plus benzoyl peroxide plus topical antibiotic. If results are unsatisfactory, prescribe retinoid plus course of oral antibiotic. Stick lesions, you see, from Christine et al. European SH guideline for acne therapy. Based on these guidelines, topical monotherapy with antibiotics is not recommended. Instead, topical combination therapy with BPO is recommended for mild papulopustular acne. Topical retinoids are recommended as monotherapy for comedonal acne or in combination with BPO or topical antibiotics for milder papulopustular acne. Topical azelaic acid therapy is the second line recommendation for comedonal and mild papulopustular acne. Topical corticosteroids shouldn't be used in treating acne. Combination therapy with topical drugs and oral antibiotics is recommended for moderate to severe acne, as well as less severe inflammatory acne which fails to respond to topical therapy alone. The systemic antibiotics shouldn't be used alone, but instead in combination with topical retinoids, BP or azelaic acid. For women, oral contraceptives containing anti-androgens are another option. The recommended antibiotics dosages are doxycycline, 50 mg daily BID, 200 mg BID, minocycline, 50 mg BID, tetracycline, 500 mg BID, and erythromycin, 500 BID. Therapy can be continued for 3 months. Yes, you see non-traditional treatment options for acne vulgaris, chemical peels, photopneumatic therapy, isolase, light, laser, and photodynamic therapy. Chemical peels, mild severe acne lesions and or oily skin type, glycolic acid or salicylic acid. Side effects of topical acne therapy: erythema, stinging, burning, desquamation, cirrhosis, bacterial resistance. Tretinoin, isotretinoin, adapalene, azelaic acid, benzoyl peroxide, erythromycin, clindamycin. Severe acne requires systemic treatment. We use oral antibiotics, hormonal anti-androgens, systemic isotretinoin. Systemic combination therapy. Topical and systemic combination therapy with oral antibiotics is recommended for moderately severe inflammatory acne as standard therapy. It should only be used for milder inflammatory acne that fails to respond to topical therapy. Side effects of systemic antibiotics commonly used to treat acne: gastrointestinal symptoms, vaginal candidiasis, esophagitis, phototoxicity, hyperpigmentation, drug-induced lupus erythematosus, cholestatic hepatitis, pancreatitis, pseudomembranous colitis, acanthaemia, headache. Tetracycline, doxycycline, minocycline, erythromycin. You see. Hormonal anti-androgen therapy is not recommended as a first-line monotherapy for uncomplicated acne. Ethynyl estradiol in combination with cyproterone acetate, chlormadienone acetate, dienogest or drospirenone is recommended only as a combination therapy for women with moderate papulopustular acne to conglobate acne. Therapy with oral isotretinoin. Isotretinoin is without question the most effective oral agent for severe acne. Efficacy of isotretinoin therapy for severe acne. You see level of evidence, different years. Dermatologists in private practice and other physicians are in a position of conflict since the publication of the European S3 guidelines, as this document once again recommends isotretinoin as the drug of choice for severe acne. The feeling is that the sooner isotretinoin is employed for acne with marked inflammation and a tendency to early scarring, the better it is for the patient. The recommended doses are 0.3 to 0.5 milligram per kilogram body weight. For severe papulopustular nodular acne, more than 0.5 milligram per kilogram body weight. For conglobate acne, therapy should be continued for 6 months, sometimes even longer. And as isotretinoin regimen of 0.15 to 0.40 milligram kilogram 1 per day revealed similar therapeutic results to treatment with 0.5 to 1 milligram per kilogram 1 per day, but with a lower rate of side effects. On the other hand, personalizing treatments by starting with a low dose 0.1 to 0.2 milligram kilogram 1 per day and identifying the highest dose tolerated by the patient may clear acne with acceptable side effects and keep the duration of treatment short with low relapse rates. Yes, Rao et al. Reported their studies prospective non-comparative study. 50 participants, both male and female, treated with isotretinoin at a dose of 20 milligram per day. Relapse occurred in 4% of the participants over a 6-month follow-up period. Their conclusion that 3 months of treatment with low dose isotretinoin was found to be effective in the treatment of moderate to severe acne vulgaris with a low incidence of serious side effects. This dose also was more economical than higher doses. Another study, Abbas et al. Reported low-dose isotretinoin was found to be a safe and effective choice for patients with moderate to severe scar-prone acne vulgaris. Length of remission following isotretinoin. About 20 to 30% of patients experience a recurrence after 1 year. Age and dose are important factors. Relapse of acne vulgaris related less to the cumulative dose and more to the length of sebaceous gland suppression, macrocomedonal pattern of acne, smoking, age, younger, under 14 years and over 25 years. The pharmaceutical quality of generic isotretinoin products. The pharmaceutical quality of generic isotretinoin products can be questionable. Among 14 generic isotretinoin products tested, 13 were not compliant with 1 or 2 pharmaceutical parameters, and 11 were not compliant with 3 or more parameters. Possible consequences of this could be reduced activity or unexpected side effects. A new isotretinoin formulation, isotretinoin Lidos, using lipid encapsulation technology was registered in 2012. Greater gastrointestinal absorption, the mean plasma level of isotretinoin Lidos is higher compared with the standard isotretinoin. Isotretinoin Lidos is not inferior to standard isotretinoin regarding efficacy. Side effects of isotretinoin: cheilitis and xerosis, increase of blood lipid, teratogenicity, induction of depression and suicidal ideation, inflammatory colitis, but not Crohn's disease, rhabdomyolysis, ocular symptoms, decreased dark adaptation, decreased vision, abnormal meibomian gland secretion, and blepharoconjunctivitis. Yes, risk of suicide. In addition to the risk of teratogenicity with systemic retinoid therapy, one must pay careful attention to the possible induction of depression and suicidal ideation. Systemic corticosteroids. Systemic corticosteroids can be administered orally to treat severe inflammatory acne, acne fulminans, and acne due to stimulated hypothalamus pituitary adrenal axis. Female patients with stimulated hypothalamus pituitary adrenal axis and functional adrenal hyperplasia due to chronic stress can be treated with low-dose oral prednisolone 2.5 to 7.5 milligram per day for a period of 1 to 2 months. Dapsone, anti-inflammatory agent, inhibits the release of interleukin 8 from human cultured keratinocytes, prevent lipid peroxidation, neutrophil recruitment. New developments, xylitol, 5-lipoxygenase inhibitor, is decrease leukotriene B4, decrease the acne severity index, decrease the total sebum lipids, normalization of the causal skin surface lipids. Atrophic acne scarring. Treatment. In the treatment, dermabrasion, subcision, skin needling, punch techniques, chemical pills, and the cross technique, tissue augmentation, fat transfer, autologous fibroblast transfer, laser resurfacing. Management of acne scars during treatment with concomitant isotretinoin. UNAIDS all reported successful treatment of acne scars using the 1550 nanometer erbium doped fiber laser in 35 patients taking isotretinoin. Acne and acne scars can be treated more effectively by concomitant use of an infrared fractional laser with low dose isotretinoin. Otherwise, there are potential legal repercussions should resurfacing treatment during isotretinoin therapy lead to complications. Thus, such treatment warrants caution, particularly for less experienced practitioners. Yes, this study, 1550 nanometer erbium doped fiber laser, 35 patients with acne scarring, isotretinoin 10 milligram per day for more than 1 month period to the commencement of the fractional laser treatment. Conclusion: acne and acne scars can be treated more effectively by concomitant use of an infrared fractional laser with low dose isotretinoin with reduced microthermal damage zone densities. Yes, conclusions. Oral isotretinoin monotherapy is strongly recommended for the treatment of severe acne, despite a range of possible serious adverse events that must be considered. It has to be administered under contraceptive protection in female patients. The pharmaceutical quality of generic isotretinoin products and the obtainability of isotretinoin through e-pharmacies add new, important practical issues to be aware of. Oral antibiotics in combination with azelaic acid can also be recommended for the treatment of severe acne. Oral antibiotics in combination with hormonal anti-androgens, topical adapalene, and or benzoyl peroxide can also be considered for the treatment of severe acne in female patients. Future anti-inflammatory systemic compounds such as the 5-lipoxygenase inhibitor xylitol could substitute systemic and topical antibiotics which induce bacterial antimicrobial resistance. Yes. Our patients who received isotretinoin before, after, similarly before, after treatment. Thank you.
Thank you very much.